Hello, students. Welcome to part 2 of assessment of the gastrointestinal system. We are going to talk right now about the diagnostic assessment. We have laboratory assessment, basically covers the blood, urine, and stool specimens. Under serum test, we have a complete blood count, right, that aids in the diagnosis of anemia and infection. GI bleeding is the most frequent cause of anemia. It is associated with GI cancer, peptic ulcer disease, diverticulitis, and inflammatory bowel disease. Then we have the prothrombin time. PT measures the rate at which prothrombin is converted to thrombin, a process that depends on vitamin K associated clotting factors. Hepatocellular liver disease leads to a prolonged PT secondary to impaired synthesis of clotting proteins. So also we're going to check for calcium to be absorbed in the GI tract and maybe measure to detect malabsorption, right? Excessive vomiting or diarrhea causes sodium or potassium depletion, thus requiring replacement. So we have excessive vomiting and diarrhea causes sodium or potassium depletion, thus requiring replacement. Is very important. This is very important, especially in the elderly population, okay? Serum enzymes are important in the evaluation of liver damage. Aspartate aminotransferase, your AST, and alanine aminotransferase, your ALT, are two enzymes found in the liver and other organs. These enzymes are elevated in most liver disorders, but their levels are highest in conditions that cause necrosis, such as hepatitis and cirrhosis. Then we have the serum amylase and lipase that may indicate acute pancreatitis. I want you to remember these two enzymes, but also don't forget protease, okay? So we have amylase is metabolizing carbohydrates, lipase is metabolizing lipids, and protease is metabolizing the proteins. A serious inflammation of the pancreas characterized by a sudden onset of abdominal pain, nausea, and vomiting. That's acute pancreatitis. But the leading roles in this condition um, are amylase and lipase, okay? So bilirubin, the primary pigment in bile, is normally conjugated and excreted by the liver and biliary system. These measurements are important in the evaluation of jaundice and liver and biliary tract functioning. Also, we have the serum level of an ammonia, which I told you, remember, is related to the liver. May also be measured to evaluate hepatic function. So, for example, if I ask you what enzymes or products are related to what organs, you need to be prepared, right? If I put amylase, you have to put pancreas, right? If I put ammonia, you put the liver, right? If I put lipase, you are not going to put a gallbladder, right? It has to be related to pancreas, okay? So that's what I need you to know. Ammonia is normally used to rebuild amino acids or is converted to urea for excretion. Elevated levels are seen in conditions that cause hepatocellular injury, such as cirrhosis, hepatitis, and hepatic encephalopathy. Two primary oncofetal antigens. This is very important. Cancer antigen CA19-9 and carcinoembryonic antigen CAI. So CEA are evaluated to monitor the efficacy of cancer therapy and assess for the recurrence of cancer in the GI tract. These antigens may also be increased in benign GI conditions. So basically, whenever you are reviewing blood work, blood results, and you're in the hospital and suddenly you say positive for CA-19-9 and levels for the carcinoembryonic antigen CEA are this, and this, then you know that the patient is positive for cancer. And then we have urine tests. Amylase can be detected in the urine. In acute pancreatitis, renal clearance of amylase is increased. Urobilinogen is a form of bilirubin that is converted by the intestinal flora and excreted in the urine. So then we are moving to a stool test, and the American Cancer Society recommends regular screening to detect colorectal cancer early when it can most effectively be treated. So we have the annual high sensitivity fecal immunochemical test, which is known as FIT, and annual WIAC-based fecal occult blood test, GFOBT, such as the Hemocolt 2 sensor, or a multi-targeted stool DNA MT-sDNA test performed every 3 years. So these tests use a take-home multi-sample method rather than having the test done during a digital rectal examination. Let's watch this video about the FIT option first, because before we go into a more descriptive mode, okay? Okay, let's watch this video.
No one really likes to talk about it, but a little bathroom talk may save your life. Having a reliable way to detect colorectal cancer early can make a big difference. The fecal immunochemical test, FIT screening method, is the standard of care for early detection. To get your test, visit your physician and request a FIT test. Once you receive your patient pack, double-check you have all the contents that should be in your pack. If indicated, clearly write your information on the bottle or requisition. When you are ready to have a bowel movement, place the collection paper inside the toilet. Collect your stool on top of the paper. Twist the green cap on the sampling bottle to open the bottle. Collect your stool sample before the paper sinks by scraping the surface of the stool sample with the wand attached to the green cap. The grooved portion at the tip of the wand should be completely covered. Now, reinsert the wand into the sampling bottle and snap the green cap on tightly. Do not reopen. Okay, just finish your business and flush the biodegradable collection paper. Double-check that you have recorded the collection date on the bottle. Then, wrap the sampling bottle in the absorbent pad and insert into the biohazard bag. Place the biohazard bag with your sample inside the return mailer. Seal the return mailer securely and drop the prepaid mailer into the mail. Your sample is perishable. Mail your sample promptly, ideally the same day you collect it. You will be notified by your medical provider about your test results. If your result is positive, it's important that you contact your doctor to schedule follow-up testing. If your result is negative, mark your calendar for 1 year from today to take this annual test again. Get screened with FIT today.
Thank you. So that's the difference between that was the explanation, sorry, about the FIT test, the fecal immunochemical test. Let's talk about the colorectal cancer incidence. Black, American Indian, and Alaska Native people are disproportionately affected by the incidence of colorectal cancer. Let me say it again. Black, American Indian, and Alaska Native people are disproportionately affected by the incidence of colorectal cancer. And this is something that can be prevented, and if it's diagnosed early, it can be treated. So patients having the WIAC-based test must avoid NSAIDs for 7 days prior to and during the collection period, as well as red meat and vitamin C more than 20 milligrams a day for 3 days prior to and during the test period. The reason is that the nutrients interfere with the chemical reaction that occurs when blood is present, increasing the risk for a false negative result. This is when we do the WIAC FOBT test, okay? The fecal occult blood test, WIAC. The WIAC fecal occult blood test. In this case, we need to avoid the NSAIDs for 7 days, the red meat, and vitamin C. So stay away from supplements and food or drinks fortified with the vitamin for about 3 days before a fecal occult blood test occurs, okay? Patients where are we? Okay. Patient adherence is likely to be higher with the FIT method because drugs and food do not interfere with the test results. Okay. In this case, FIT, they don't have any specific requirement like the WIAC. Okay. So, okay, let's continue. As an alternative to the WIAC, FOT, or FIT, a multi-target stool DNA test can be completed every 3 years and is available only by prescription. This type of at-home diagnostic kits, such as Cologuard, is shipped directly to the patient after the healthcare provider has ordered the testing. Although less specific in detection than a colonoscopy, this type of testing can be encouraging to patients who may be fearful of undergoing a traditional colonoscopy or have concerns about financial coverage. Okay, so I gave you website with the Cleveland Clinic specifications about the types of colon cancer screening. You can read about the FIT, the difference to the WIAC, FOBT, and the Cologuard. Okay, those are the three. Although false negative or false positive results are possible, home-based screening tests are a cost-effective tool for identifying colorectal cancer. All positive results might be followed up by a colonoscopy for further investigation. So if you got positive results in your home-based test, then you go for further investigation and probably the PCP is going to order a colonoscopy. So here you have your laboratory profile for GI assessment. Here you have your liver enzymes, your ALT. Also, you have your albumin, which is going to be increased in case of dehydration, your alkaline phosphatase in case of cirrhosis, liver tumor, or intrahepatic or biliary obstruction is going to be increased, ammonia, amylase, your AST, bilirubin. Here are the levels also. Your calcium, we spoke about this, 9 to 10.5 are the normal values. And also additional tests like cancer antigen CA 99, which I already spoke about. Also the carcinoembryonic antigen CEA, your cholesterol levels that you should know by heart right now, lipase, potassium, and other levels. Okay, so let's move forward. People who have a personal or family history of colon cancer, who have a condition that places them at risk, such as inflammatory bowel disease or Crohn's disease, which is IBS and IBD. IBS is irritable bowel syndrome, and this is IBD, inflammatory bowel disease. Do not get confused, okay? Get into the habit to recognize inflammatory bowel disease or Crohn's also. And the other one is irritable bowel syndrome, okay? Or Patients who have previous positive results from another type of colon cancer screening test should be taught that a traditional colonoscopy is preferred over an at-home test. What else? Stool samples may also be collected to test for ova and parasites to aid in the diagnosis of parasitic infections. They may also be tested for fecal fats when steatorrhea, fatty stools, or malabsorption is suspected. Fat is normally absorbed in the small intestine in the presence of biliary and pancreatic secretions. I want you to know this concept because we're going to talk about pancreas in the future and gallbladder, okay? In malabsorption, fat is abnormally excreted in the stool. In malabsorption, fat is abnormally excreted in the stool. Stool samples can also be tested to detect the presence of infection agents, such as Clostridium difficile, a common cause of diarrhea in older adults and patients on prolonged antibiotic therapy. And if you are working in the hospital as a medical assistant, as a CNA, PCA, LPN, and you enter a unit with a patient that has C. diff, the entire unit smells C. diff. It could be 40 patients in one unit, but the moment you step in the unit, you know somebody is having the C. diff. I'm telling you. Okay, that's good to know. Okay, a plain film of the abdomen may be the first X-ray study that the healthcare provider requests when diagnosing a GI problem. This film can reveal masses, tumors, and strictures or obstructions. Patterns of bowel gas appear light on the abdominal film and can be useful in detecting an obstruction, ileus. Okay, no preparation is required except to wear a hospital gown and remove any jewelry or belts which may interfere with the film. When abdominal pain is severe or bowel perforation is suspected, an acute abdomen series may be requested. This procedure consists of a chest X-ray, a supine abdomen film, and an upright abdomen film. The chest X-ray may reveal a hiatal hernia, or an upright abdomen film may show air in the peritoneum from a bowel perforation. Although X-ray are helpful, diagnostic ultrasound and CT are used more often. Okay, this is a type of test, right? That is taking a lot of different pictures, right? Through X-ray. The American Cancer Society screening guidelines include the following imaging procedures as option to determine the presence of colorectal cancer and polyps in adults older than 45. So the requests have changed. It's not anymore 50. Right now it's 45. And that's good to know. NCLEX alert. So they accept the flexible sigmoidoscopy every 5 years. Flexible sigmoidoscopy, which is an endoscopy of the sigmoid colon, right? It's a colonoscopy. They use an endoscope, right? Um, and this one does not require anesthesia, if I am not wrong. Then you have the CT colonography, virtual colonoscopy every 5 years. And if they find something, then you have to do the colonoscopy. And then you have the colonoscopy every 10 years if everything is okay. If not, if some polyps are found, or depending on the history of the patient, they can repeat the colonoscopy every 3 or every 5 years. CT, also referred to as a CT scan, provides a non-invasive cross-sectional X-ray view that can detect tissue densities and abnormalities in the abdomen, including the liver, pancreas, spleen, and biliary tract. It may be performed with or without contrast medium. So if contrast medium is ordered, ask about any previous reaction to contrast medium and identify all severe allergies to medication. The patient is to remain on nothing by mouth, MPO status, for at least 4 hours before the test if a contrast medium is to be used. Also, they are going to use MRIs such as magnetic resonance cholangiopancreatography. Because of the use of powerful magnets, the patient will be asked about the presence of any medical implants, and precautions are taken to ensure that the patient meets requirement for this type of testing, right? Another NCLEX question. The nurse is caring for several clients who wish to use a home-based screening test to identify possible colorectal cancer. Which of the following clients would the nurse recommend receive a colonoscopy instead? Select all that apply. So then you have the answers are A, client whose mother died from colon cancer 20 years ago because of the genetic evidence, right? Um, a patient with a history with Clostridium difficile is not the answer. Client undergoing current treatment for Crohn's disease, yes. And then client who uses laxative, no. Client with positive fecal occult blood test in the past, yes. Other diagnostic assessment, you have endoscopy. Is direct visualization of the GI tract using a flexible fiber optic endoscope, a tube that allows viewing and manipulation of internal body areas. It is commonly ordered to evaluate bleeding, ulceration, inflammation, tumors, and cancer of the esophagus, stomach, biliary system, or bowel. Specimens for biopsy and cell studies like Helicobacter pylori, which we are going to discuss in next chapters, which is the terror in the upper GI, can be obtained through the endoscope. Okay, here we have a video about the another test which is called esophago gastroduodenoscopy. So the name is telling you what area the endoscope is going to visualize: the esophagus, the gastric area, and the duodenum. Okay, let's watch this video so we can understand much better this examination in detail.
Upper endoscopy is a test that looks inside the upper gastrointestinal or GI tract. The GI tract includes the esophagus, stomach, and duodenum, which is the first part of the small intestine. The test is also known as an esophageal gastroduodenoscopy, or EGD. It's done using a tool called an endoscope, which is a long, thin, flexible tube that has a light and a tiny camera. The test helps find problems such as ulcers, infections, or growths. It can show the causes of swallowing problems or dyspepsia, nausea and vomiting, acid reflux, bleeding, and abdominal pain. Before the procedure, you may have a physical exam, blood tests, or other kinds of tests. You'll be asked not to eat or drink for at least 8 hours before the procedure. Tell your healthcare provider about all the medicines and supplements you take, any allergies you have, and if you're pregnant or might be pregnant. Your healthcare provider will explain what happens during the procedure. He or she will also talk with you about any risks or complications that may occur. You'll be asked to sign a consent form that gives your healthcare provider permission to do the procedure. Read the form carefully and ask questions if anything is not clear. An upper endoscopy takes about 20 to 30 minutes. When it's time for your test, you may be given medicine to help you relax or sleep. This is called sedation. This medicine is usually given through an intravenous line, put in a vein in your arm or hand. Your throat might be numbed with a spray or liquid, and you'll be given a small plastic guard to protect your teeth. During the test, you lie on your left side, and the endoscope is placed in your mouth and moves down your throat. Air is used to expand the GI tract so your provider can see the lining more clearly. You may feel some pressure or discomfort from the air. The scope sends pictures of the GI tract to a video screen. Your provider looks at your esophagus, stomach, and duodenum for problems such as bleeding, inflammation, or growths. Using small tools inserted through channels in the endoscope, he or she can take small samples of tissue to send to a lab. This is called a biopsy. In some cases, your provider will remove small growths. The endoscope is then removed. After the test, you'll need to rest for about an hour to let the sedation wear off. This kind of medicine lasts for a while in the body, so you'll need a family member or friend to drive you home. Plan to take it easy for the rest of the day. If you had a biopsy, the results will be ready in about 7 days. Call your healthcare provider if you have any of the following: nausea and vomiting, vomiting blood, stomach pain that doesn't go away, black tarry or bloody stools, trouble swallowing, or fever. To learn about more procedures and screening, please subscribe and support us. In the next video, we will show the colonoscopy procedure, so stay tuned. Thank you.
Thank you so much. So basically, this is a visual examination of the esophagus, stomach, and duodenum by means of a fiber optic endoscope. If the patient has a esophageal stricture, a narrowing of the esophageal opening, it can be dilated during EGD, esophago-gastroduodenoscopy. Gastric lesions can be visualized using this procedure, and suspicion for celiac disease can be affirmed. So this is a very, very interesting and very useful test, even for this type of disease, celiac disease. You see the importance. Usually patients are asked to avoid anticoagulants, aspirins, and other NSAIDs for several days to a week before EGD unless it is absolutely necessary. So you see, in terms of colon cancer screening, when you do your colon test, your screening home-based test, you also need to avoid the NSAIDs and vitamins and red meat. Right here, you have to avoid anticoagulants, aspirin, NSAIDs for several days to a week before EGD unless it is absolutely necessary. The patient can take regularly prescribed medications the morning of the test unless otherwise instructed by the healthcare provider. Teach the patient to remain NPO for 6 to 8 hours before the procedure. So after the test, check vital signs as with every single procedure. Frequently, usually every 15 to 30 minutes until the sedation begins to wear off. The side rates of the verve are raised during this time. Keep the patient NPO during the until the gag reflex returns, and usually is 30 to 60 minutes. And this is good to know, NCLEX alert. So another NCLEX alert: safety, the priority for care to promote patient safety after esophagogastroduodenoscopy is to prevent aspiration. Remember, I put you the diagram of the trachea and the esophagus. So you want to prevent aspiration. Those two canals are very close to each other, right? You want to prevent aspiration. Do not offer fluids or food by mouth until you are sure that the gag reflex is intact. Monitor for signs of perforations such as pain, bleeding, or fever. In general, in summary, if you know your map, if you know your anatomy and physiology, you are safe, because the critical thinking is gonna tell you, right, we need to prevent aspiration. These two pathways are close to each other. Because EGD is most often performed as an ambulatory care procedure requiring moderate sedation, be sure that patients have someone to drive them home. Common sense. Remind the patient not to drive for at least 12 to 18 hours after the procedure because of sedation. 12 to 18 hours. It's not that I'm having the endoscopy at 12 and I'm gonna go to work at 6. No, no, no. You need to take the day off. Explain that a hoarse voice, right? Because this procedure was done next to the area where we have the vowel sounds, right? Explain that a hoarse voice or sore throat may persist for several days after the test. Throat lozenges can be used to relieve throat discomfort. And this is a common feeling after endoscopy. So safety, safety, safety. Another one is endoscopic retrograde cholangiopancreatography. And this includes visual and radiographic examination of the liver, gallbladder, bile ducts, and pancreas to identify the cause and location of obstruction. It is commonly used today for therapeutic purposes rather than for diagnosis. And we are going to watch this video. This is, I would say, two procedures in one because kind of uses x-ray and also the endoscope. Okay, let's watch this video.
Endoscopic retrograde cholangiopancreatography, ERCP, is a procedure that combines endoscopy and fluoroscopy to diagnose and treat disorders associated with the pancreatic and biliary ductal systems, as well as the liver, gallbladder, and pancreas. Endoscopy is a medical procedure in which an endoscope, a thin, long, flexible tube with a light and tiny camera at one end, is inserted into the body to examine an internal organ or tissue in detail. Fluoroscopy is a medical imaging technology that uses radiography or a continuous X-ray beam passing through your body to produce real-time moving images of a body part being examined on a monitor. Surgical procedure. You will be asked to lie on an examination table for the procedure. The procedure may be performed under sedation and local anesthesia or general anesthesia. An intravenous IV needle will be placed in your arm. After administering a local anesthetic to the throat, your doctor will insert an endoscope through your mouth, esophagus, and stomach to reach the first part of the intestine called the duodenum, where the bile and pancreatic ductal systems open. A small camera mounted on the endoscope captures images which are magnified and viewed on a monitor. Your doctor will locate the opening where the bile and pancreatic ducts empty into the duodenum. A catheter will be inserted through the endoscope into the ducts, and a special dye called a contrast medium will be injected into the ducts through the catheter to make them more visible on X-rays. Fluoroscopy, live X-ray imaging, is performed to identify any areas of blockage or other abnormalities. Your doctor may then pass tiny tools through the endoscope to open blocked or narrowed ducts, remove or break up gallstones or excise lesions. Temporary stents may be inserted to keep the ducts open or to avoid bile leaks that can occur after gallbladder surgery. The procedure often takes between 1 and 2 hours.
Thank you very much. So we know right now what is the endoscopic retrograde cholangiopancreatography. This procedure is not a joke. I know too many people, not only relatives, but also close friends that have developed peritonitis after this procedure. And there are also other friends that because they are obese, the procedure couldn't be completed. So when they are trying to put the stent couldn't be placed because of the excessive fatty tissue. So they have to remain in the hospital for approximately 3 weeks. This is not an easy procedure, okay? The patient must be NPO for 6 to 8 hours before the test. After the test, assess vital signs frequently, usually every 15 minutes until the patient is stable. That's logic. To prevent aspiration, check to ensure the gag reflex has returned before offering fluids or food. Discontinue IV fluid that were started before the procedure when the patient is able to tolerate oral fluids without nausea and vomiting. So after the ERCP, Teach about the importance of monitoring for unexpected yet severe post-procedure complications, as I told you, including cholecystitis, pancreatitis, infection, which is your peritonitis, bleeding, perforation, and biloma. Fever is present in sepsis. These problems do not occur immediately after the procedure, and this is the most important part. They may take several hours to 2 days to develop. So whenever you feel the procedure was successful, after 2 days, bloom, you have sepsis or peritonitis. Okay, NCLEX alert. So let's go to a small bowel capsule endoscopy or enteroscopy. Let me repeat. A small bowel endoscopy or enteroscopy provides a view of the small intestine. Video capsule endoscopy is a procedure that uses a small bowel enteroscopy device to visualize the entire small bowel, including the distal ileum. So let's watch another video because that's the only way we can understand these procedures.
A capsule endoscopy is a test that we do to look specifically at the small intestine. It's a pill camera that we have patients swallow, and the camera takes images from everything from your mouth until you pass it. The images we're specifically looking for is the small intestine because that's an area that they're not able to reach by either upper endoscopy or colonoscopy. The reasons that we would do this test are to look for any abnormalities within the small intestine. Commonly, we look for sources of bleeding if people have anemia or have low iron counts. We also look for people who have Crohn's disease. We look for any sort of inflammation within the small intestine. And then there are also genetic conditions that people produce polyps, something called FAP, and we use the capsule endoscopy to examine the small intestine for that as well. This is the capsule. It's about the size of a fish oil pill. It looks worse than it is. It's very smooth, so people don't have any issues swallowing it typically. And it has 16 lights, and it also has 4 cameras, so it gives us a 360-degree view of the small intestine. This also has a hard drive in it, which stores all of the images, which we later download and review to see what your small intestine has within it. To prepare for the capsule endoscopy, it varies based on what your provider prefers as well as what capsule system they are using. Some of the providers have you use a partial colonoscopy prep the day before to clean out your system. Other providers require you to do a clear liquid diet the day beforehand. What this will do is flush out your intestinal tract so that the camera can get a clear view. The capsule endoscopy, you do not feel any symptoms with it. It's similar to taking any other pill that just travels throughout your intestinal tract, and then you'll pass it in your stool. Some of the systems require you to retrieve the capsule, and if that's the case, you will receive instructions in the kit to retrieve it. Others, you have to wear a recorder for the day, similar to a Holter monitor that stores all of the images. And in that case, you pass the capsule in your stool and it gets flushed down the toilet. If the capsule does get stuck, it typically will reveal the underlying issue which was causing the symptoms in the first place. If you do have any concerns, please reach out to the office and speak with your provider directly.
Thank you so much. You guys need to know all these procedures because you're gonna come across, either if you work in a hospital or in the gastroenterology clinic or maybe on a primary care clinic, you are going to come across reports that are going to describe all these tests, and you need to know and you need to be familiarized. Okay, so that was the small bowel capsule endoscopy. Now let's get into the most important, the colonoscopy, right? The American Cancer Society recommends that beginning at age 45 years, which is a big change from the time I used to study nursing, it was 50 years. All healthy men and women should have a colonoscopy every 10 years or choose another equal effective recommended screening as we described before. We have 3 types of this screening home base, right? As we described before. So evidence currently shows that younger adults with obesity are developing colon cancer, possibly due to chronic low-level inflammation that leads to cancer over a period of time. Those at high risk for cancer are the ones with family history or those who had polyp removed, and they need to have the test done more often. As I said before, when they do the colonoscopy and they find polyps that are removed, probably the gastroenterologist is going to ask you to come back in 3 years or 5, depending on the amount of polyps and the nature of the tissue of the polyps. Okay, so let's watch the test, the colonoscopy video. Okay.
A lower GI endoscopy, also called colonoscopy or sigmoidoscopy, allows your doctor to view the mucosal lining of your lower gastrointestinal tract. The procedure is used as a screening test in individuals with no symptoms or to help diagnose unexplained abdominal pain, rectal bleeding, or a change in bowel habits. It is capable of detecting inflammation, infections, ulcers, diverticulosis, intestinal narrowing, colorectal polyps, cancer, or other problems that may be present. Before the procedure, you will need to undergo bowel preparation. Depending on the type of medication prescribed to you, you will start 1 to 3 days before the procedure. You will need to modify your diet as well as take medication, which will help to clear your bowels in preparation for the procedure. The procedure is performed using an endoscope, which is a long, thin, flexible tube with a light and a tiny video camera attached to the end. The camera transmits an image to a monitor. In a sigmoidoscopy, the endoscope only reaches to the top of the descending colon. In a colonoscopy, the endoscope reaches through the entire length of the colon to where it connects to the small intestine. The presence of the endoscope and the air may cause you to feel cramping or pressure and the need to pass gas. This is considered a normal part of the procedure. Your doctor may ask you to change your position slightly to help maneuver the endoscope more easily through the curves of your lower intestine. If you experience pain, tell your doctor immediately. In some cases, your doctor may find it necessary to take a biopsy. A biopsy helps distinguish between benign and cancerous tissues and can help determine the cause of bleeding, inflammation, or diarrhea. Biopsies are often taken even when your doctor does not suspect cancer. If 1 or more polyps are discovered, your doctor will generally remove them in a procedure called a polypectomy. He or she will usually use a snare to remove the polyps, and then cauterize their bases to control bleeding. At the end of the procedure, the endoscope will be removed from your colon. A sigmoidoscopy usually takes about 20 minutes, while a colonoscopy can take 30 minutes to an hour.
Thank you so much. So, okay, so remind patients to avoid aspirin, anticoagulants, again, the same recommendations, and antiplatelet drugs for several days before the procedure. This is to prevent bleeding, right? Patients with diabetes should check with their primary healthcare provider about drug therapy requirements on the day of the test because they are MPO. And I know many patients that they show up for the procedure, and then if they are waiting for 1 or 2 hours before the colonoscopy and they feel that they are getting into the hypoglycemic area, they just tell the doctor, I'm done, I'm not going to do the colonoscopy, even though they went through the whole preparation. So this is very important to consider. The healthcare provider will prescribe the specific method of operation for the bowel, which begins the night before the procedure. And they are also going to get a liquid diet the day before the scheduled colonoscopy, an electrolyte replacement drink. Maybe they are going to they need to avoid red, orange, or purple gray beverage or gelatin. The patient should be NPO for several hours before the procedure based on the healthcare provider instructions. And all this paragraph is good to know, NCLEX alert. So the failure to achieve adequate bowel preparation prior to this procedure can lead to decreased visualization of adenoma or unsuccessful colonoscopy. If you are in the hospital and the patient is ordered a colonoscopy and you are taking care of the patient, right? And you are administering the liquid, the preparation for the colonoscopy. Let's say you are finishing your shift and the patient is still is drinking, right? That preparation, and you fail to report the following nurse and the colonoscopy is not clear enough, you're putting the health of the patient in jeopardy. So try to master all these steps, because either it's going to be for a patient in a hospital, either it's going to be for a family member, or it could be you who needs to know this procedure really good. Okay, the patient is going to be placed on the left side and with the knees drawn up while the endoscope is placed into the rectum and moved to the cecum. Remember, for colonoscopy, they are going to put an IV access to administer the moderate sedation. The patient is going to place on the left, and the endoscope is going to be placed into the rectum and moved to the cecum, meaning, so it's going to enter the rectum, the sigmoid colon. After that, it's going to go through the descendant colon, then to the transverse colon, all the way going down to the ascendant colon to the cecum. That's the trajectory the endoscope is gonna go in the colonoscopy. If we are talking about sigmoidoscopy, the endoscope is entering the rectum, going to the sigmoid colon, and going only to the upper part of the descendant colon. Okay, that's the difference. Okay, so the entire procedure is gonna last 30 to 60 minutes. Follow-up care, check vital signs every 15 to 30 minutes until the patient is stable, maintain NPO status, and keep the side rails up until the patient is fully alert. And we need to provide comfort. We need to look for passing flatus, observe for signs of perforation, which would be severe pain and hemorrhage, such as a rapid drop in blood pressure. That's why you need to monitor your vital signs every 15 minutes. Fluids are permitted after the patient passes flatus to indicate that peristalsis has returned. Basically, with all these tests, we are looking either for gag reflex if it's an upper endoscopy, or flatus of peristalsis if it's a colonoscopy. If a polypectomy or tissue biopsy was performed, there may be a small amount of blood in the first stool after the colonoscopy. Now let's talk about virtual colonoscopy, a non-invasive imaging procedure to obtain multidimensional views of the entire colon is the CT colonography, known as virtual colonoscopy. The bowel preparation, virtual doesn't mean that the colonoscopy is going to be a Zoom meeting, okay? No. It's a virtual colonoscopy. The bowel preparation and dietary restrictions are similar to those for traditional colonoscopy. However, if a polyp is detected during a virtual colonoscopy or if bleeding is found, the patient must have a follow-up invasive colonoscopy for treatment. So at the end, it's better to have a regular colonoscopy instead to avoid double testing, right? Best practice for patient safety and quality care of a patient after a colonoscopy. Do not allow the patient to take anything by mouth until sedation wears off. Take vital signs every 30 to 30 minutes. Keep the patient in lateral position to promote passing of flatus. Keep the top side rails up until the patient is alert. Assess for rectal bleeding or severe pain. I want to tell you, sometimes when sedation wears off, patient starts crying. It's normal. They become very emotional. I don't know what is the explanation for that. Maybe because of the sedation, the effects of the anesthesia in the nervous system. I've seen some patients with that effect. Assess for signs and symptoms of bowel perforation, abdominal pain, fever, hypovolemic shock. Basically, those are the most important factors. Sigmoidoscopy basically is what we saw in colonoscopy, but only the endoscope enters through the rectum, sigmoid colon, and all the way up to the descendant colon. That's sigmoidoscopy. And then health literacy, something to consider. Personal health literacy, the degree to which people can find, understand, and use information and services to make health-related decisions varies dramatically among people. Assess all people to determine if they fully understand testing procedures and requirements by having them explain the test, preparation, and follow-up in their own words. So whenever you are documenting and you are typing patient verbalizes understanding, it's not something that you type as protocol. It's because really the patient verbalizes and repeated all the instruction that you taught them. Okay. Ultrasonography is a technique in which high-frequency inaudible vibratory sound waves are passed through the body via transducer. Ultrasonography is commonly used to view soft tissues such as liver, spleen, pancreas, and biliary system. The advantages of these tests are that it is painless, non-invasive, requires no radiation, or requires no specific preparation. This is an ultrasound, right? Endoscopic ultrasonography is something different. So we're going to watch this video to understand what is the endoscopic ultrasound. Okay, once I find the video. Okay, here it is. Okay, here we go. We're almost done.
Endoscopic ultrasound is an endoscopy procedure using a special endoscope with ultrasound capability. It is used for the purpose of evaluating internal organs of the chest and abdomen, along with the lining of the gastrointestinal tract. It can be used in children weighing more than 15 kilograms. The flexible echo endoscope is passed through the mouth into the stomach and small intestine. It can be used for diagnostic purposes to visualize adjacent organs, lymph nodes, and blood vessels. Here we see ultrasound images of the pancreas. Use of the echo endoscope allows for visualization of the pancreas within close approximation of the stomach wall, particularly the tissue and ductal structures. In addition, EUS procedures can obtain tissue from organs or abnormal tissue adjacent to the stomach or small intestine to assist in making a diagnosis. In this example, a biopsy is obtained from the right lobe of the liver to assist with diagnosis in a patient with elevated liver enzymes. In addition to biopsies, endoscopic ultrasound guidance can be used for drainage of pancreatic pseudocysts or walled-off pancreatic necrosis, along with other intra-abdominal fluid collections. Here, a needle is passed through the stomach wall into a pancreatic pseudocyst, followed by a wire through the needle. The newly created cyst gastrostomy tract is then dilated with a balloon. Plastic stents are placed to keep this tract open and allow the cyst fluid to drain into the stomach. These will be removed in a few months when the pseudocyst has resolved. A larger, lumen-opposing metal stent may be used for walled-off pancreatic necrosis. Cincinnati Children's provides endoscopic ultrasound and other advanced endoscopic procedures to patients of all ages.
Thank you so much. And this procedure is very complete, right? You see that you have the endoscope. Also, once the endoscope is inside the area of interest, they are going to perform the ultrasound. And from there, they are going to do biopsies and they are going to remove fluids. They are going to place stents. This is a very complete procedure. Okay, so liver spleen scan. A liver spleen scan uses IV injection of a radioactive material that is taken up primarily by the liver and secondarily by the spleen. The scan evaluates the liver and spleen for tumors and abscesses, organ size and locations, and blood flow. Teach the patient about the need to lie still during the scanning. Provide assurance that the injection has only a small amounts of radioactivity, because this is the reason why many patients, they don't want to perform certain procedures because they are scared from the from radiation, right? And is not dangerous. As female patients of childbearing age, if they may be pregnant or are currently breastfeeding, the radionuclide can be found in breast milk, and radiation from X-rays or scan should be avoided in pregnancy. Let me make a comment here, a parenthesis. So basically, some patients, they don't want to go through radiation. They want to avoid mammograms or maybe this time of radioactive procedures. But at the same time, they are having at home microwave, right? And they are warming up food day and night, which is another type of radiation. So we have to make a balance, okay? We have to be logic. So in summary, we have the endoscopic for the upper GI, endoscopic studies. Then we have the ERCP, so endoscopic retrograde study. Also for the areas in which the endoscope and the colonoscopy cannot assess, for example, the areas of the small intestine, we have the small bowel capsule endoscopy, right? And then we have the colonoscopy and the sigmoidoscopy. And on top of that, we have some different home-based tests like the FIT, we have the WIAC, FOBT, and also the Cologuard, which is the DNA type of test. So there is a variety of tests to prevent all this type of cancer, either in the upper GI tract or the lower gastrointestinal. And there is a lot of preventive tests to identify if the patient is having different disorders. So with all these tests, images, and laboratory assessment, we conclude the assessment of the gastrointestinal system. So stay tuned. We are coming back with more. Thank you.